So welcome everyone who is joining us now. My name is Rebecca Garcia. I'm the president of the Nevada Parent Teachers Association, and we are happy to have you joining us tonight for this health and safety town hall regarding reopening schools with Nevada health experts. I'm joined co-moderating with me today by Allison Turner, our Vice President of Advocacy. So again, thank you for joining us. This town hall is part of a series that we are doing related to issues that impact Nevada families and children. And of course, a really hot topic right now is regarding reopening schools and how that impacts the health and safety of our students as well as teachers. And so we are incredibly grateful that we have a panel of true experts with us today who really understand these issues. I have to say that would not be me. I was not the science kid. Yay for science, but it wasn't me. So I'm glad to have you guys with us to be explaining that for us tonight. We're going to start with brief introductions. Because of some different technical challenges, not everybody was able to be on video, but we wanted to make sure that this information still moved forward. So again, some are on audio and some are on video, but we will introduce everyone and then get straight into the questions. And people are welcome to add questions into the feed as well in case you weren't able to submit in advance. So Allison, would you introduce our first panelist?
I would be delighted. I'd like to introduce Heather Kerwin. She is the director of epidemiology program manager for epidemiology for the Washoe County Health District. She has a master's in public health with a focus in epidemiology. She's worked in infectious disease epidemiology in New Mexico and has consulted with various entities across Nevada for several years. She has worked as a statistician, and when not working, she enjoys time outside in the garden, skiing, and hiking. So it sounds like Reno Tahoe is a really good place for her.
We are also joined on the phone by Yvette and Wintermute. I apologize, I just messed up that. But Yvette is the proud Health Services Director and Chief Nurse for the Clark County School District. She's worked for the Clark County School District as a school nurse since 2000 in various capacities, including as a nurse administrator. She also has an MED as well as being a registered nurse. I didn't ask you any of your hobbies, Yvette. So if you want to add a favorite thing, you're welcome to do that.
Well, in non-COVID times, I love traveling, so.
yeah, not something you're doing a lot of right now, but thank you, Yvette, for joining us.
No.
Thank you, Yvette, for joining us tonight.
And so last but certainly not least, I'd like to introduce Dr. Ihsan Azzam. He is the Chief Medical Officer for the state of Nevada. He oversees public health surveillance, epidemiology, and disease control activities. Dr. Azzam advises state and local health authorities, healthcare providers, and community-based organizations, as well as providing professional education, guidelines, clinical updates, and recommendations to prevent, control, and contain disease outbreaks. Dr. Azzam represents Nevada on state and national forums, advisory bodies, and academic institutions, and coordinates investigations and surveillance activities among state, local, and federal agencies. Dr. Azzam earned his medical degree from Cluj, I'm going to lose the last part and I apologize, Cluj-Napoca, University of Medicine in Romania in 1982. He completed his OBGYN residency in 1986. He also holds a Centers for Disease Control and Prevention graduate certificate in epidemiology, biostatistics, and demography from the University of Seattle School of Public Health and Community Medicine, and a CDC chronic disease epidemiology certificate from the Penn State College of Medicine. It looks like he also does something at the University of Nevada, but I can't really that one didn't quite come through. Nevertheless, Dr. Azzam, thank you so much for joining us this evening. We really appreciate you.
Thank you so much for this long introduction.
Well, Dr. Azzam, we're going to hop right into questions. And so, you know, for many of us, data and charts have become a daily thing that we look at, something that wasn't a common part of our life before. Can you explain some of the key statistics that the state is monitoring right now related to the coronavirus?
Thank you. This is a really great question. In order to monitor the spread of the virus and to assess our risk for contracting the infection, the most elementary variable we monitor is incidence. We just want to know how many cases we have or new cases we have every day. When the number of cases increases, that reflects an increase in the spread of the virus in the community. Certainly, when you test more people, you will find or you will detect more cases. Now, if you test 100 people and you found 10 positive, that is very similar if you next day tested 1,000 people, so you increase the rate of testing, and you found 100 people. Both of them are 10% positivity rate. While if it happens that you tested 1,000 people the other day and you found 150 to be positive, now your positivity rate is 15%. And that tells me that there is something else more than increasing testing that is going on, which is increasing the spread and the transmission of the virus in the community. And that is something which we need to be able to suppress or to reduce. And there are countries which were able to reduce that to minimal rates. Now, talking about hospitalization or hospitalization rate reflects the severity of the infection, regardless if it's COVID-19 or any disease. If it takes us to the hospital, it means it's serious. While we know that in COVID-19, more than 80% of the people have either mild or moderate symptoms, the rest of the people may have serious symptoms, and some of them are severe and may require hospitalization. And some of them, they're really critical and may require to be in the ICU. And we know that higher numbers of deaths occur among hospitalized, and we know that more than 3/4 of those who make it to the ICU die. And that's why we need to be able to reduce the number of, or the total number of cases. So the 20% of individuals who may have severe cases will be lower. Why we need this number to be lower? Because we want our healthcare system not to be overwhelmed. We do not want to be able to see really that the hospitals are running out of beds and ICUs are full, and we evaluate that daily, how much percentage of the beds are gone in hospitals and how many ICU beds we have and how many people are on ventilator. Because if this number increases a lot, we may overwhelm the healthcare system. And remember that other dangerous diseases like stroke or heart attack or asthma or even broken bones and car crashes are happening, and we need to let the healthcare system be able to have enough capacity to deal with that. So again, the more cases in the community, the more we are are at high risk to contract the infection, and the more we can overwhelm our healthcare system and not to give them the capacity to deal with other diseases. Now, with schools, sorry.
Yep, that's just where I was going to ask. How do you use this data in relation to schools, especially the decisions about the safety of reopening or having kids in person?
Remember really that schools in communities where we have no cases or very little cases, they are at lower risk to have cases among school and people, being students or being staff or teachers. That's why we need to be able to suppress the numbers. Remember really that schools do not only have students, they have also older people and individuals with pre-existing conditions. And we need to do our best to suppress the virus. And that can happen in our community by following the physical distancing or the social distancing, using masks, regular hand washing, environmental disinfection. And also really we can say that having a plan, and we saw that really in Nevada, we saw the plan developed by the Department of Education addressing all these areas. So we need to be prepared. And just I want to emphasize that we cannot expect to be totally safe while the pandemic is going on. So what we are striving is to be as safe as possible and as prepared as possible and addressing all scenarios, because most probably we will have cases in school and we need to be able to deal with that. And one final note, having had said that, recent studies showed that kids are at lower risk to contract the COVID-19, and subsequently they are at less spreading the infection to others or to the elderly.
Thank
I
you,
will
Dr.
stop here. And
Thank you, Dr. Azzam. We have more questions for you, but I think Allison is going to ask the next question of someone else.
Yes, the next question is for Ms. Kerwin. We see so much discussion around recommendations from the CDC, from the American Academy of Pediatrics, and from the states, as well, all changing as conditions change, of course. Ultimately, the consensus seems to be that local public health information and recommendations should be the deciding factor for reopening schools, which makes sense as conditions vary so widely, as Dr. Azzam just pointed out. Can you help us understand how that works from a public health perspective?
Sure. So under the Nevada revised statutes and the Nevada Administrative Code, there are a bit over 60, 70 reportable conditions that are mandatorily reported to public health departments, specifically those that are communicable, vaccine preventable, and then in instances like this, when you have rare or unusual diseases of occurrence or novel and pandemic-like diseases of occurrence. So we receive these reports and we can, to Dr. Eisen's point, that we're using the data to help inform that, the decisions that we make or the guidance that we might provide, or, developing kind of some early alert systems around that. So we're the central clearinghouse for the data, and we have knowledge of those who are diagnosed in our community. In a non-pandemic setting, we work closely with our school partners because we're tracking and declaring outbreaks that are influenza or gastrointestinal outbreaks. Probably many families are familiar with norovirus, unfortunately. And so in those instances, we'll work closely with the schools. And again, the underlying goal is to prevent the transmission of illness. And we know sometimes our tiny germ factories are the best conductors of those, depending on the diseases and that you're really working with. So it's really a two-way street. I would say that, we need to have a great understanding of how things are actually working on the ground in the school to be able to help them prevent and still provide an education and services to students. And not just with, thinking of the infectious disease itself and the impacts of those students, but the impacts to the school system and the longer lasting impacts in an educational career of students who are having to miss a lot of days of school. So we really want to think more proactively. We know we're doing a good job if there's an absence of disease in a community in a normal setting, again, in a non-pandemic setting. So in reopening schools, I think specific with this one, we here in Washoe County, and I think across most of the state, have been really attuned to this since mid-January. So even weeks before a lot of the rest of the US was really tracking what was going on with the novel coronavirus. So thankfully, we've got it feels like a lot of time behind us now in working in this. And, in terms of reopening, we definitely find the value. There's other things that go on in a school besides just transmitting of germs back and forth. It's obviously education is one of the primary drivers of health outcomes and longevity and quality of life. And we know that students often rely on school meals in a school setting. So we try and take all of these factors together in decisions on whether or not we should reopen or keep them closed. But really, it's a lot up to the prevention tactics that a school district can afford to or really feasibly put into place to determine if the reopening is going to be successful or not. And we do know that anytime you have people congregate, and we've had this happen time and time all year long, that it really does seem to erupt and spread much much more readily than had you have put into place a lot of social distancing. So, you know, with the CDC recommendations being kind of the forefront and the guiding federal facility or federal organization for this, we try and standardize across the country and then follow in steps. But I think there's always these little nuances again, you know, as Dr. Ihsan mentioned, that in communities where they don't have widespread transmission happening and there's very few cases, it would absolutely, you know, make sense to completely open as you would any normal school season.
Different circumstances based on different communities really seems to be a theme with public health, right? You're very localized in how you track a lot of what you do. Dr. Azzam, face coverings are obviously something that's key in the state right now. You as the Chief Medical Officer, why are face coverings important right now?
It seems that at the beginning of the pandemic, and while we had in our country very, very limited spread of the virus, CDC decided to save our limited supplies of masks and other protective equipment for healthcare providers who are dealing with cases, and mostly severe cases. And initially, it wasn't very clear that many cases of COVID infection have no symptoms. They are asymptomatic. And not only that, many other proportion are pre-symptomatic. So they will be symptomatic, but unfortunately, both these categories are able to spread the infection to everyone without showing any signs and symptoms. And that's why they were probably talking and coughing and breathing and infecting others, and we didn't know. Many studies, and many of them in the US and out of the US, showed that face mask is significantly effective, as effective as physical distancing or social distancing. Even it could be more effective than that. And as we see that the stay-home measures are being lifted, we are trying to reopen the economy and reopen schools. Our professional interactions in the community are going to be more frequent. So face mask, is acting like a physical covering, a physical barrier. In the old times, we used to use our hands to block our sneeze and cough. Certainly that is not good because it will infect our hands. Now we know really that the face covering is able to block the spread of the droplets from the virus in the environment. And that's really important because it doesn't really only protect others from our coughing and sneezing and singing and loud speaking, where we can spread our droplets with the virus. It also protects us from their coughing and sneezing, and it reduces the concentration of the virus in the environment and the air, because this virus is hardy and may live for a few minutes just hanging as droplets in the air.
So
One last thing I want to add.
Go ahead.
That today the CDC issued in their morbidity and mortality weekly report a study which showed that two symptomatic hairstylists interacted for a significant period of time with 139 clients. The stylist has their face covering and the clients had their face covering. So that exposure, you would think, would result in a lot of infections because the virus is highly infective. Actually, it did not result in any infection, which tells me that the face covering is essential. If we want to weather this pandemic, I think the second best after social distancing is the face covering or face mask.
Yeah, it seems to, again, I admit it, science wasn't my thing in high school or college, but it does seem, if we can reduce that transmission, then we're just better and we can keep more things open. And I think that's something that's really concerning for a lot of people. I'm going to jump a little bit ahead and ask Yvette Wintermute, who's on the line with us, a question kind of related more to kids in school with masks. There's a couple questions that came in related to that. there's a lot of concern that kids are going to touch their mask. They're going to take it off. They're going to play with it. And then people feel like, well, then what's the point of having the mask on at all? So what would you say to that, and why are many districts, Washoe being one, CCSD being another, asking for children, even young children, to be wearing face coverings?
Remember having, sorry, go ahead.
Oh, I just saying, I was just referring to what Dr. Azzam said. It's very important. We could provide education to those younger students and something that's developmentally appropriate so they understand the importance of wearing the mask. And we have to try. And I think Dr. Azzam accurately described it. It's just very important that we protect ourselves and protect others. And the mask is one key way.
So even if kids are touching it, them wearing it most of the time would still provide enough benefit, and that's why you're recommending it? And that can be for anybody to answer.
Yeah, just let me jump in here that remember that not having a mask, the barrier or the physical barrier value will be 0. While having a mask, it will be definitely more than 0, and that is not bad, better than nothing. The second thing is that the face mask is recommended with other measures, such as having at least 3 feet distance between young students, because remember, they cannot comply with the mask. And also they are young, which means really that the risk of contracting the infection is lower. As the risk increases with age, older age groups like high school students, I would say that they will have better compliance with the mask. So I would really would sacrifice the mask, although they can use it as much as possible, toward enforcing or implementing other measures such as hand washing and being able to cohort kids with their teachers. And one last thing is that teachers should have the mask, because we don't want them also to spread the virus to their kids or to each other or to other staff.
So it's that whole I've heard it's on the Facebook, the memes and stuff. My mask helps protect you, your mask helps protect me, right? So we all need to participate to help each other. Yvette, one of the other questions that came in about schools is people are concerned about the safety of wearing masks during recess or athletic activities, things like that, when kids are active. What is the guidance regarding masks throughout the day at school?
Well, CDC has determined that masks are safe for healthy children. There are those group of kids that won't be able to wear masks as far as if they have difficulty breathing or they're otherwise incapacitated and not able to remove their own face covering. So there's always going to be that group. However, that's why we also are planning to maintain social distancing and educating on that. So in those instances where maybe the student isn't able to tolerate a mask because of activity or whatever else going on, they would be still maintaining social distancing even if that's outside. So I don't know if Dr. Azzam has anything else to add about the student physical activity and the mask, but that's kind of the basics there as far as school.
Most of physical activities occur in the outside, so not in a closed environment. And the idea of using masks for younger people or for children and school children is, again, additional. We know that they are at lower risk of contracting the infection. So whatever we can add to the traditional measures for preventing infection is great. And truly, the mask is very effective. If they will use it even 20% of the time, is better than using it 0% of the time.
So it really sounds like it's that kind of multi-tiered, having all the mask, the social distancing, and again, not 100%, but rather everything we can to make it better is what I'm hearing. Allison, I'll turn it back over to you for the next question.
Sure. I'm actually going to go back to Dr. Azzam, and then we're going to go on, continue our round robin, if you will. So, Dr. Azzam, one of the big questions that we hear is, how is COVID-19 different from the flu? there's been a lot of misinformation from time to time, and this still remains a really big question in the minds of our families and also our community members.
Thank you. Again, influenza virus and COVID-19, both are RNA viruses, and they share several symptoms, except for COVID-19 symptoms can be significantly severe in about 1 in 6 of the patients. Remember that the flu virus comes once every year. We know when it starts in the autumn and winter, and we know when it ends. We do have a vaccine. It causes usually upper respiratory infection. It doesn't really reach the lungs and the lower part of our respiratory system. It's really rarely we get difficulty breathing if we have influenza, although some people with underlying conditions, they may, but the general situation is that it's upper respiratory. It doesn't impact the lungs. One more thing, that we do have treatment for the flu. We do have Zofluza, we have Tamiflu. These are effective treatments. We know that the case fatality, which is the number of the patients with the flu who die from the flu, is less than 0.1%. And it doesn't exceed 36,000 deaths in the US every year. And people who have the flu, when they recover, they usually recover well, and they don't really have long-term consequences. The one bad thing about the flu is that it mutates a lot, and that's what makes the vaccine partially effective, but still it's very effective, and I hope everyone will take the vaccine during this season especially. On the other hand, we don't really know a lot about the COVID-19. It just emerged. We have 6-7 months of knowledge on this virus, and we are really not sure what exactly to do in order to deal with this virus. So we went back to old techniques such as isolation and quarantine. So the more important thing, that infection, while it can be severe, it usually has affinity. They like to, the virus, the COVID-19 likes to infect the lower respiratory tract, the lungs. It may cause pneumonia. And we know really that a significant number of the elderly and people with pre-existing conditions do have complications, and they get hospitalization. We do not really have a vaccine, unfortunately. We do not have effective treatment yet. And the case fatality of COVID, unlike the influenza, is 1.4 to 4.5%, which means really that the death is 14 times to 40 times more happening with COVID than with influenza. 40 times more than influenza. And that is really the difference, in my opinion, between these two RNA viruses.
Thank you so much, Dr. Azzam. That I think that's going to help clear up a lot of that area of question for a lot of the folks that we work with and try to serve. If I may, I'd like to take the next question to Ms. Kerwin. I guess, especially this would fall under epidemiology. Can you give us an idea of how at-risk children are contracting COVID-19?
So there is some research regarding the risk of contracting it. I think, we'll know more once we look back. A lot of the articles that are coming out, because it's so novel, really need to be proven with redundant repetition, right, in the studies. We do know from talking to over 2,000 cases and over 3,000 now, when there's families with a confirmed case in the household, some of them know, because we ask about symptoms of everyone in the house, and we say, how are the children, and have anybody experienced symptoms? And it's frequent that the kids, when they do experience symptoms, it's really just a little blip in their week. It's like a couple of days of maybe a low-grade fever, maybe some diarrhea, a scratchy throat. Fortunately, we haven't spoken to parents of, or, you know, teenagers who have their parents' permission to speak with us directly, they're just hacking and coughing and febrile for days, like we see in the non-pediatric cases, so those over 18. Really, and those over, you know, 25, 30 is where we start, you know, you can hear how sick they are over the phone. So it's good to know. You know, we always are really concerned about those who are under the age of 1 in any instance. Usually those infants don't necessarily display the same symptomology as an adult or even an older child might. And so there's a lot there that we want to be hyper conscientious about. Especially, you know, if they're not presenting with those typical symptoms, we just want to make sure that they're eating, you know, behaviors and that are what would be expected for that child. But then the cases that we've seen, they seem to just have a few days to the point where the parents they're not even concerned about getting them tested. You know, but again, they can transmit to others. And of course, you know, it's more difficult to get them to do those preventive efforts. You know, they're always putting their hands in their mouth, putting their hands on everything else. So that surface contamination would be, you know, of concern. And it's really difficult to explain to a child why you need to socially distance and what that means. And, oh, you're getting too close, and they want to, you know, give hugs and be right up in the action. So definitely just from an exposure risk itself, we're concerned because, you know, it's tough to tell them the real, you know, the reasons behind why they need to do what they need to do, and why maybe everyone's behaving differently socially around them, and everybody else now. But fortunately, when we've seen the kids here, they haven't displayed those traditional symptoms that on the acute infection. Of course, there is, you know, the concern with the multi-inflammatory syndrome. They abbreviated the MIS-C, so in children, but that presents itself after the acute infection typically, and we have been conducting surveillance across the state to see if there's any of those cases that we have missed. It's presenting similar to a disease that's very rare called Kawasaki's disease, and there's a lot of different biomarkers that are kind of indicative of this, and some of the nuanced differences between those two diseases. But the underlying factor here is inflammation, which is never good for any system. And so we'll continue to be on the alert for that. But fortunately, it seems to be fairly rare relative to the number of cases that we see just of COVID overall.
Well, I think you actually covered my next question to a great extent about schools and why restrictions would be, you know, something important to look at least. So I'm actually going to move on to maybe a broader topic, and I'd be interested certainly to hear, Ms. Kerwin, what you think, but I'd also like to hear from Ms. Wintermute as well as Dr. Azzam. There's been so much new data on individual immunity, its strength, and apparent time limits on it. And so how sound do you feel that the theory of herd immunity is at this point in time?
So I'll kind of kick this one off and then turn it over. Herd immunity is the concept when enough people have an infection right around you that they've built up a natural immunity to it. And so the ability for a virus or a pathogen to pass from person to person is greatly reduced because no one's actively getting sick from this. So they're not replicating, in this case, viral copies to then shed and infect other people. Herd immunity is really reached at 70% of people have to have this immune response or more. And then you'll start to see kind of a natural, I don't want to say complete disappearance, but kind of a natural decline or plateau, if you will, in cases. We have done here in Washoe County actually what's called a seroprevalence study, and the CDC has seroprevalence studies going on at different sentinel surveillance sites across the nation, and it varies from coast to coast, but overall there's not any communities that are really above, and this was, you know, data as of a few months ago, there weren't any communities that were really looking at above 2 to 5%. So we're well below that 70%. And I've even seen some of the research that's coming out of Spain, which, you know, was relatively hard hit as well. And they're not finding anywhere near as high of, you know, anywhere near that 70% that they were thinking. I believe it's also down maybe in the 10 to 12% highest there. So it would really take a lot of people getting, unfortunately really sick, and then having a long-lasting immunity. And what we know about this coronavirus is it's part of the family of coronaviruses. There are other coronaviruses, and they cause the common cold, and everyone probably has caught the common cold several times in their life. So there is a likelihood that this has waning immunity. And, again, if you see enough different variation in strains over time, it could be something that you could catch the different strain. So that is concerning, but again, having time behind us will help inform that a little bit more, but we're nowhere near, as a country, or even locally, anywhere near the percentage, proportion of the population with a natural immunity to this that you would hope to see once you would confirm herd immunity.
I'm sure others could jump in, but we are running short on time for the amount of questions that we still have left. And so I want to, and nobody minds, I want to move on to another one. It's been a hot topic, and this one, it relates to schools, but I think anybody else who wanted to jump in as well. There's been a lot of questions regarding screening protocols, temperature checks, personal or parental health screenings for their children. Can you help us understand the different plans for screening protocols, and especially like why maybe temperature checks would be recommended, or why in some cases they're not being included as part of plans?
Would you like me to?
That.
Go ahead.
I think Yvette will start, and then whoever wants to add anything.
Okay, for Clark County School District, we did consult with our Southern Nevada Health District, and we did look at the feasibility of possibly screening all our 320,000 students and 40,000 employees, over 40,000 employees, and it was determined not to be feasible. Meaning, for example, if we had a large high school of population of 3,000 and they're waiting in line to have their temperature taken, and our hot temperatures here in Las Vegas, we would see most likely a lot of false positives, a lot of fevers by the time they would get checked, and then that would create more of a delay and possibly exclude students that didn't need to be excluded. So for our school community in Clark County, it will not be feasible for us to check every student's temperature and every employee's temperature prior to school starting daily. But we are providing education to parents and guardians and to staff about monitoring their own health and checking their students before coming to school.
So maybe
I'll
Dr.
turn it over
Ihsan,
if anybody has anything.
Yeah,
so maybe
let me jump in here.
Yep.
Go ahead.
No, I was just going to say, go right ahead.
Yeah, actually, it's I would say because little kids and young children have mild symptoms, many of them also do not even have temperature. And I would say the most qualified to know if the child is not feeling well is his parents. His mom would know really that the kid is not feeling well, and that's the time when the child doesn't feel well, shouldn't really even go to the bus or go to school. Now, if somebody would say, how would I know if this is allergies or this is the flu or is it stomach flu or norovirus or whatever? And the answer is any symptoms of infection requires us to keep our kids at home. Because honestly, I don't see how practically schools or the bus driver will be able to screen kids. I think the parents should be able to identify kids who are not feeling well, and just even if it's allergies, they need to keep the kid at home until the symptoms go away, because we don't know if this is allergy or infection.
Yeah, I think that's, we've used the term asymptomatic a lot. We've also used the term novel several times, and we probably should explain those. And I think you did, Dr. Azzam, a little bit at the beginning, but again, so if you're asymptomatic, you have the virus, but you're not showing, you don't have a temperature, you're not saying that you're sick, right? So there's people walking around potentially spreading the COVID-19 with no idea that they even have the virus, correct?
Correct.
And then novel just means that this is a unique strain of the coronavirus. Is that a correct layman's way of saying it?
It's new. It's
Okay.
newly emerging. It wasn't on this earth before the end of last year.
Okay.
The virus.
Because I think sometimes I know I'm a news junkie, so I've been hearing those terms a lot, but I think sometimes other people may not. And I also, Dr. Azzam, I really appreciate you bringing up because I am a mom and I have kids who are 9 and 11 and 13, and sometimes, you know, they just don't want to go to school, or they don't feel good, or they have allergies. And I think that is really important that we as parents make the decision and recognize that we don't need to guess. If they are showing any symptoms, they just need to be at home, period. Because there's no other way around. You know, I don't have that degree, and there's just so much uncertainty. So I appreciate you saying that, and I think that's important for us as parents to take that to heart and follow that guidance. So then I'll give it back to Allison to ask our next question.
And it really kind of just ties right back into this. This is really for you, Ms. Wintermute. Can you give us an idea of what kind of training staff will be provided with to help them determine when a student needs to go to the health office? And sort of the corollary question to that is, what about trainings for FASAs or health office aides?
Yeah, so we have trainings geared towards, as we mentioned, parents and guardians for helping to check those signs and symptoms of illness before they come to school. We have trainings that we're developing for both staff and office personnel and our first aid safety assistants. So those trainings are geared at recognizing signs and symptoms of COVID-19, the ability to quickly recognize that a student is showing those signs and when to contact the health office upon detecting those signs. Okay.
Sorry, forgive me if I interrupt you very briefly. Can you give us an idea of how those trainings are being provided, especially to families? Like through what medium?
Yes, we're developing short videos that we hope to be shared out. We're partnering with, for example, our Vegas PBS and other type media, and planning to work with our communications department too to get those pushed out to parents. They will be provided in Spanish as well. And that's the primary means, is through short videos for that group.
That's really wonderful, because that's probably one of the best ways to communicate. But the reason I brought it up was just, you know, all the difficulties that we've had, you know, making sure that families have devices and have connectivity. And so that, you know, that's where that can get lost in that communication. I beg your pardon. I did kind of digress there. Sorry about that.
Oh, that's all right. That's all right. No, it's a good question. Thank you. Anyway, providing the trainings for symptom recognition and ability to quickly recognize, and for teachers, what steps they need to take when they recognize somebody or student ill in their classroom. So sending them up to the health office, and then for our health office staff, whether that's the first aid safety assistant or maybe a health office backup, to ensure the student has a mask on or provide a mask if they're able to wear one, sending them to an area or isolating them in a designated isolation area so that we minimize the exposure to other students and staff that might be walking to the office or that type of thing. And then quickly getting them home to be treated, or also providing training on recognizing the more serious signs and symptoms that are urgent, as far as difficulty breathing and possibly needing to call 911. So we would ensure that those would be followed, and that we would get students to a higher level of care if they needed it at that time.
I would add also that the school would contact the local health district. So an investigation will be to evaluate those who were immediate contacts.
Right. As Dr. Azzam mentioned, yes, we have very good communication with our Southern Nevada Health District. Many times they might be contacting us to inform us that a student's been COVID-19 positive based on testing that the family's done or that has been done at their healthcare provider. And in that case, we would work closely with them to provide the needed contact tracing for class lists or bus rosters, any sort of specials that the student might be in. And we provide that information back to the Southern Nevada Health District. So yes, thank you. That's a good reminder. They're a very big stakeholder in this, and provide us direction on what information is needed in terms of if they're considering a school closure, or what other students need to be quarantined, that type of thing.
I think that leads perfectly. You guys already answered half of the question that we have got several times, but Ms. Kerwin, I'm going to ask you, like, how does If I'm a parent or if I'm a teacher, one of the biggest questions is, how will I know if somebody I've interacted with tests positive, and then what happens next? So could you, like, from my point of view, if my son was in a class with somebody who tested positive, how would I find out? What would need to happen? And I know quarantine recommendations change based on the current situation, but if it was today, what would happen?
So the first thing to do is go back to the source case. You want to confirm that they did have a diagnosis that confirms that they did have it. You do an investigation with that case, that family, and it's really important to determine the onset date. So the date that the symptoms began, because that then frames around when they were infectious. So let's say a kid goes home from school on a Friday and they're completely fine Saturday, Sunday, and they wake up, Monday morning and they don't feel so good and they don't go to school, because our infectious framework starts at -2 days from symptom onset. It would actually be the best case scenario, because they wouldn't have been considered to be infectious while in school on Friday. But we would do our contact tracing around that infectious period, and we say, okay, -2 days from symptom onset. So we're starting on Saturday through Sunday, and then we're working our way through the time when we're speaking to them, or at least through their time that they're infectious. And at that point, we do our contact tracing, which I'm sure many of you have heard about in the news, but we're finding out where they went, who they were with, and who was considered to be exposed. And at that point, or right now, we're working around an exposure framework that is anyone who is within 6 feet of someone for 15 minutes or longer. So this is where it's really helpful to know, like, a layout of a classroom. For example, if someone were considered to be infectious while attending school in person, and the layout of the classroom and who was most in that 6-foot bubble, and then, did they go out and have recess with anybody? Do they know who they played with? Does the instructor know who they most, frequently maybe hang out with inside the classroom? So it's really important. There's additional questions that we may ask, like the teacher, if the child is not able to identify those factors for us, to really make a clear determination in who was exposed, because we don't want to put people in quarantine unnecessarily. It can be detrimental. Families have to stay home from work with kids who are not able to care for themselves. And we certainly don't want to be overreaching with that. So we want to make a really careful, delineation between who's exposed and who's not. And we either may go back to the school, or if the families know each other, we can solicit contact information. But we would do the same that we would do with any other positive case that we uncover right now, is we'd make a phone call. We'd provide them with the isolation and quarantine guidance and materials. And we'd say, this is the guidelines for you, given that this was your last date of exposure to someone, or your child's last date of exposure to someone who had been infectious at the time of their contact with one another. And this is what you can expect for that 14-day period following that day. So there's a lot of legwork that goes into it, but that's part of the case investigation and contact tracing. And so we'll, contact that that parent and that family. It wouldn't be, if the classroom is really unsure, or the teacher's really unsure what the kind of interactions were, the safest bet is to just then exclude everyone in that classroom. If you can't be certain, then it's better to be able to make the right call and be a little bit more conservative with that. And so in that instance, we would make the phone call to every family in the classroom, and we would really, it's a lot of hands-on work, but that's what we've been doing so far, and it's, it's working as it should. So that's, what we would do. We don't want to necessarily send a letter, because we get a lot of alarmed parents, and it generates a lot of phone calls and questions about, well, my kid's in that class, and I'm like, well, I don't have the layout necessarily of that classroom. I can't speak to that. So that's what we'll try and do whenever we find a positive case in a classroom, and same with the buses and other places that children may be coming to and from school.
Okay, I appreciate that. There's still, Dr. Azzam, quite a few questions in the Facebook Live feed regarding temperature checks, and a lot of discussion related to why shouldn't every teacher just check every kid when they walk in the door at their classroom. Could you maybe touch on that a little bit more, about why temperature checks maybe aren't as useful as maybe some people think, or maybe why that's not included in all of the recommendations?
To be honest with you, if it's practical, if it's doable, I think it's no harm to do it. But waiting to get the temperature or evaluate symptoms until the kid went into the bus, interacted with other children, and went into the classroom, that would be too late. Certainly, I wouldn't oppose multiple layers of screening for children. Certainly, screening them several times is no harm at all. The issue is that the most essential one is while they are at home and while they are seen by Dr. Mom, because the mother and certainly other family members would know the most if the child has mild symptoms. Because when we say really that the person is asymptomatic or pre-symptomatic, it doesn't really mean that they do not have clinical symptoms at all. These symptoms could be subclinical. They're underappreciated. We don't really see it, while probably family members and the mother may see that the kid is not exactly how feeling as happy or as active as he usually or she usually is. Certainly, if we can do it at the bus, I see really that is great, but doesn't seem practical because one driver will do it outside, and just we heard about the horrible temperature of 100 would really not provide good reading. And in the classroom, certainly I'm not opposed to having the teacher doing it, but that would be too little too late.
Yeah, thank you, Dr. Azzam.
One thing, if I could add to that, the temperature checks, many cases don't ever experience a temperature, and if they do, it's a low-grade temperature. So if someone shows up with a 99, it's not technically a fever till it's 100.4 degrees Fahrenheit, and it's usually not the first symptom someone presents with. So there's a lot of other things to be on the lookout for besides the classic fever that everyone's kind of really acutely attuned to.
Thank you.
I know we're running out of time, so I'm going to try to slip one more in here. There's also a lot of discussion around ways that the coronavirus can be spread. And so if any of you or all of you could take a stab at the difference between aerosol transmission, meaning relatively large droplets being sneezed or coughed or exhaled, that we also now understand that there can also be more general airborne transmission of much smaller droplets, which may actually linger longer because they're not as heavy and they don't fall. And then finally, surface contamination and what that adds to the issues with contagion. Who'd like to go first?
I would just take a stab on that.
Thank you, Dr.
The transmission or the mode of transmission of COVID mainly is through droplets. So whatever really, when we talk or we yell or we sneeze or cough, these droplets will go out. Unfortunately, the virus is hardy, is stable in the environment more than other viruses. These droplets may continue to be hanging in the air for a few minutes, depends on how hot that day is and the humidity level. So the transmission is mostly through droplets. Certainly, if I sneeze, if I have this, I sneeze on a counter or on a doorknob or in my hand, and then I touch a doorknob, that surface is contaminated. And several cases were recorded from people who touched a contaminated surface, and they touched their nose or their eyes, or their face. So practically, the virus is, the mode of transmission is really complex. Talking about airborne transmission, I would say really the word airborne, it's overrated because the droplets, if they are very small and they're hanging in the environment, in a closed environment, certainly the virus will live for 3-4 minutes. And a person who comes into the room may get the infection. An example of real airborne is measles, where if I go into a place where somebody had measles, even without a lot of coughing or without coughing at all, I can get the infection 1 hour later. because it's really airborne and transmissible from one place to another. And having had said that, there were few cases reported which were suspected as airborne, but the main mode of transmission is through droplets and also through contaminated surfaces. And the virus lives on contaminated surfaces days, for 3, 4, even up to 6 days.
Wow, thank you very much, because that, again, that's just been an area where there's been, so much conversation, discussion, and confusion. So thank you. I think that laid it out very well, Dr. Azzam. Ms. Kerwin or Ms. Wintermute, do you have anything you want to add to that? That certainly goes into, how we're going to clean surfaces and all of that sort of thing. So any other comments there?
This is Yvette. I know we've worked closely with our facilities department to ensure they have basically reviewed all the cleaning procedures and are doing extra cleaning, even now with school being out. So we plan to continue that as school reopens.
Great,
and
thank you so much.
The only thing I would add to that is just because, that primary transmission being that droplet, and then, the airborne, that it's super important to, if you can, open doors, open windows, decent ventilation. Any ventilation, again, is going to be better than no ventilation at all. So really reducing the concentration of viral particles in a certain area can definitely reduce risks.
And gee, that also
That's
leads
a
right
great
back
point.
to a mask, doesn't it?
Exactly.
Absolutely.
Yeah.
Go ahead, Dr. Azzam.
Yeah, I was just really saying that the example which I gave, which was published by CDC, that if every party, if I have a mask and other people have a mask, the rate of transmission was 0, even if there were 2 cases who were symptomatic, which means that their viral load is high and they're more infectious. So I think the mask and the social distancing and the ventilation are really essential. And one point which I really want to emphasize, that in schools, cohorting students with their instructors is really essential, because this would limit the level of exposure if any one of the kids or the staff comes down with the infection. And certainly we want the staff also to be 6 feet away from other staff and from their kids, and right from the class kids. And also we want them to use the mask at all times.
Thank you, Dr. Azzam. I think that was really important. We hadn't covered cohorts yet, so I appreciate that you brought that up, because I do think that that's a question. A lot of parents ask, why do they only have to go part-time? Nevada has the largest class sizes in America, and so in order to get those smaller numbers with that 6 feet of social distancing, we're seeing a lot of districts across the state come back and say we need to do cohorts. So I appreciate you clarifying that. So we are out of time. We probably could have gone for another hour, but you guys have already stayed way past, well, Heather, I know all of you were actually still at work doing stuff. So you guys are all working long hours anyway, but we appreciate you joining us tonight and sharing this information for parents and teachers as we look at what happens next. And with the numbers in Nevada, I think there's still a lot of unknowns as to what will happen next with schools. But I do want to offer, if anybody wanted to share a final thought, and then we will wrap it up.
I'm thinking that I want just to give a comment about the herd immunity, because I feel really that we can really make it clear that natural herd immunity is not practical, is not doable. What Heather mentioned, the 70%, because if you can look now, we have 3 million cases in the US confirmed, and we have 136,000 deaths. So to reach 70% herd immunity, it means 210 million people have to be infected. And the death rate will go between 4 to 6 million. That is extremely high price. The only herd immunity which we can attain is hopefully through a vaccine, which hopefully we will get effective FDA approved vaccine. And the other thing is that this natural herd immunity, which we get from the infection, we don't know for how long it will be. Is it durable? If we develop enough antibodies to protect us, we don't know. The experience with this virus is less than 8 months. So eventually, I think counting on natural herd immunity, like incorrectly, Sweden, the country of Sweden, tried to do that, and they found out that they have extremely high price of mortality. And now they're reverting back to social distancing, face mask, hand washing, and environmental decontamination, and the specific measures which everybody knows. They are not that great, but these are the only tools where we can fight back against this virus until a vaccine or effective treatment are already approved, or when we will have them approved.
Those are sobering numbers. And as a mom, you know, I just always think that there's so much unknown, and that is what worries me about my kids. You know, it might be simple or mild for them, but we don't know. And so what can we do to keep them safe? So with that, I think that's a good closing thought. Sobering, but important as we face a situation the world is, you know, really trying to come to grasp with. And we appreciate all of you joining us tonight. And for those who are watching on playback, thank you for tuning in. And thank you, all of you, for the hours that you're putting in. On behalf of parents and families and teachers, I know you are spending long hours trying to provide the best information possible to the citizens of our state and the residents. And I thank you for that, because I'm sure you are exhausted. And I thank you. So on behalf of Nevada PTA, thank you, Allison, for being my co-pilot tonight, our Vice President of Advocacy, and all of you for joining us. And we will say good night.
Thank you all so much.
Thank you.
Good night.
Thank you.
Thank you. Good night.
Bye-bye.